And today I'm going to be doing a little lecture on cardiovascular physiology. Could someone just shout out and say if the slides are up?
Yeah, we can see them. Thank you.
Perfect. So today we're going to cover ECGs, medications to do with cardiac physiology and dysrhythmia, factors that affect cardiac output, blood pressure, Starling forces, and then a bit about the neural control of cardiovascular physiology at the end. This is all on your spec under section 8.6. It is quite a big section, so I haven't screenshotted it and put it in here, and we won't be covering all of it, but hopefully we'll go over the principles that are important. So to start, we're going to be having a look at electrical activity in the heart. So the heart contracts because of electrical activity, which originates from the sinoatrial node up in the atria there on the diagram. This then travels through the atria, making them contract, and goes through the atrioventricular node. Between the atria and the ventricles, there's the annulus fibrosus, which is non-conductive tissue. So this means that all the electrical signals are channeled through the AV node, down the bundle of His and up the Purkinje fibers, which then cause the ventricles to contract. This system means that contractions happen in a way that blood can be pumped efficiently out of the heart, and it's not just pumping blood in a random manner. Potential is a little bit different from the regular action potential in nerves. It's worth knowing that it's made up of a few phases. It's sodium that causes depolarization in phase 0, and then these sodium channels close and calcium and potassium channels opening, causing phase 2 there, which you can see on the diagram, which cause the contraction, and then rapid repolarization once the calcium channels close and potassium is just left. This is all initiated, as I said earlier, in the sinoatrial node, which has a special type of action potential. This is the resting potential of these cells are more positive compared to ventricular myocytes, and slow sodium channels are responsible for the depolarization, and this is called the funny current. The way we measure electrical activity on the heart is with ECGs. So you need to be aware of the 3-lead ECG, which is shown on the left, and 12-lead ECGs as well. So this involves placing stickers at different points, which then can record the electrical activity between the 2 points of the stickers. And this should pull up a trace that looks like this. So you need to be aware of the P wave, which is at the beginning of an ECG trace, which represents atrial depolarization. This then should become the QRS complex, which represents ventricular depolarization, and finally the T wave, which represents ventricular repolarization. ECGs are helpful because they can show certain pathologies in the heart. So for example, if there are no P waves, it's likely that there's atrial fibrillation, where the atria don't always contract and don't always have a regular electrical impulse. Similarly, if there's a broad QRS complex, then this is a sign of ventricular fibrillation. Other things to look out for are heart blocks. So this can be various degrees. So 1st degree heart block is the least severe kind, and it just means that impulses take longer to reach the ventricles. And then on an ECG, this is shown as a PR interval of greater than 120 milliseconds. Next, there's 2nd degree heart block, which is where electrical signals intermittently fail to conduct through from the atria to the ventricles. There are several different types of this, such as Mobitz type 1, type 2, and 2-to-1 block, which all have slightly different representations on the ECG. Finally, the most severe type of heart block is the 3rd degree heart block, which is where there's no conduction between the atria and the ventricles. We're going to move on to a bit about the pharmacology of cardiac contractility now. So there are antidysrhythmics can be classified in different ways, and one of the ways which you should be aware of is the Vaughan-Williams classification. So there are 4 classes. Class 1 are sodium channel blockers. Class 2 are beta adrenergic antagonists. Class 3 increase the duration of cardiac action potential, and class 4 are calcium channel blockers. On your spec, there are an example of these that you need to know. So for class 1, that's lidocaine. For class 2, that's propranolol. For class 3, that's amiodarone. And for class 4, that's verapamil. And these all act in slightly different ways to provide that antidysrhythmic effect. Outside of this classification, you also need to be aware of adenosine, which binds to the A1 receptors located in the nodes, which cause hyperpolarization and slow the pacemaker potential to provide an antidysrhythmic effect. Cardiac glycosides also can be used as an antidysrhythmic. These block the sodium-potassium pump, which causes sodium to build up in the cell, activating the sodium-calcium exchanger, meaning that calcium will then build up in the cell, which increases contractility. And eventually this means that there is an increased cardiac output at a lower rate, which has an antidysrhythmic effect. So we're now going to talk a bit about cardiac output. On your spec, this is 8.6.2 and 8.6.7. So the cardiac cycle consists of the atria contracting, blood flowing then into the ventricles. The atria then relax, and then the ventricles contract, causing blood to flow out of the ventricles, either through the systemic or the pulmonary circulation, depending on which side of the heart that you're on. This can be shown nicely in the diagram to the right of your screen, which shows the differences in pressures in the aortic, the aorta at the top, which is the top black line here, the left ventricle, which is this line here, and the left atria, and the pressure changes across the cycle. You can also see that heart sounds occur at different points. So the first sound is here as the mitral and tricuspid valves close, and then the second heart sound is the sound of blood flow as the pulmonary and aortic valves close. This can also be represented on the volume pressure curve, which is something you should be aware of. If you start at point A on the diagram there and follow the purple line across, you can see that's showing ventricular filling as the volume increases and the pressure stays broadly the same. Then the mitral valve closes at point C, and you go into isovolumetric contraction, which is where the volume stays exactly the same, but the pressure increases up to a point which at D, where the aortic valve opens, and the pressure increases while the volume starts to decrease again up until point E, as the ventricles are contracting, and then finally the pressure will decrease again. The volume, will decrease to F, at which point the aortic valve will then close. There'll be isovolumetric relaxation where the volume stays the same, but the pressure reduces, and then you get to point A again, and the cycle repeats as the heart contracts and relaxes. So it's important to be aware that cardiac output is determined by stroke volume times by heart rate. Stroke volume is the difference between the end diastolic volume and the end systolic volume. Parasympathetic innervation goes to the SA and AV node, and sympathetic innervation goes to the SA, AV node, and the ventricles. And and it's important to be aware that cardiac output is affected by many different factors. Normal cardiac output at rest is 5 litres per minute in a male. The Fick principle explains that cardiac output can also be determined by the difference in the volume of oxygen in the arteries and the veins, and that basically describes the difference between, is a way of calculating cardiac output by the amount of oxygen that's been consumed through the body. The Frank-Starling curve is another principle that you need to be aware of. The principle of this behind this is that as there's greater venous return, there's a greater stroke volume, and this is due to stretching of the ventricular myocytes and can kind of be explained like an elastic band, and if they're stretched more, then they will bounce back with a greater force. Another principle to be aware of are the principles of preload and afterload. So preload is similar to the Frank-Starling effect and describes the muscle fiber stretch at the beginning of contraction. And the afterload is the force opposing the muscle contraction. So in the aorta, how much blood volume there is. If there's a higher afterload, then for a given pressure of the heart, less blood will be pumped out. And that's represented there in those graphs. So, as I said earlier, sympathetic innervation goes to the SA, AV node and to the ventricles. This is largely on beta-1 adrenergic receptors, which activate cyclic AMP, causing sodium and calcium to enter the cells and faster depolarization and at the SA node and conduction at the AV node, causing a faster heart rate and increased cardiac output. This cyclic AMP pathway also activates protein kinases, and this can cause calcium channels opening, increasing intracellular calcium. It causes calcium to exit from the sarcoplasmic reticulum, causing increased intracellular calcium and faster reuptake of calcium after the release from the sarcoplasmic reticulum, causing faster contraction. And this all leads to increased contractility of the heart as well as the faster heart rate. So these systems can be targeted pharmacologically. So adrenoreceptor agonists, beta-1 agonists, which are specific to the heart, such as dobutamine, can be used to stimulate the effects that they have, so a faster heart rate and increased contractility. And antagonists can be used to slow down the heart rate or prevent the heart rate increasing in times of fight or flight, such as propranolol. The parasympathetic system, as I said earlier, impacts the SA node and the AV node. This is through acetylcholine, which acts on muscarinic receptors and causes potassium channels to open. This causes rapid hyperpolarization of the cell and reduces the action potential frequency and the speed of contraction, overall causing a reduced heart rate and reduced cardiac, and therefore a reduced cardiac output. This too can be targeted pharmacologically with antimuscarinic drugs such as atropine, which can be used to treat bradycardias. So now we're going to move on to a bit about hemodynamics, which is 8.6.4 on your syllabus. So you need to be aware, blood pressure varies through the heart cycle. So when the ventricles pump, this will cause peak blood pressure, and as they relax, this will gradually drop until the heart contracts again, causing blood pressure to rise, and so on and so forth. And this difference is called the pulse pressure. The mean arterial pressure can be calculated by the equation, which is diastolic pressure plus 1/3 of the difference between systolic and diastolic pressure. And normal blood pressure in the systemic circulation is 120/80 milligrams per mercury. So central venous blood pressure is described as the blood pressure in the right atrium or the vena cava, as the right atrium can be tricky to measure clinically, as it's quite invasive. It's important for you to know that the difference between mean arterial pressure and central venous pressure is equal to cardiac output times systemic vascular resistance. So now we're going to move on to a bit about the properties of the circulation, which are points 8.6.3 and 8.6.5 on your syllabus. So as I've alluded to, and I'm sure you all know, the circulatory system is made up of two parts, with the left ventricle pumping blood through the systemic circulation to the body, and the right ventricle pumping blood to the pulmonary circulation. This is because the two systems need to be pumped at different pressures, with the left side in systemic circulation being at, as I said, 120/80, and this high pressure is needed so that the body is well perfused, whereas on the pulmonary side of the circulation, a much lower pressure of 20/10 is needed, as the tissue in the lungs is very delicate, and if it was pumped at such a high pressure, then it would be destroyed. And then, as you know, I'm sure you know, the system from the ventricles goes through arteries to arterioles to capillaries, where the transfer of oxygen occurs in tissues, and then goes to venules and veins, which then are collected and go back to the heart. So the heart is the primary pump, but it's worth also knowing that in your legs, there's something known as the venous muscle pump. So as you walk or contract your legs, this helps pump blood back up the veins to the heart. And this is why veins have valves in them and arteries do not, so that blood can be pushed up these veins and then not fall back down with gravity. This is also why you may see people that have stood still for a long time fainting, such as in surgery or the Queen's or King's Guards, because they're not using their venous muscle pump and their blood pressure will drop, meaning they'll have reduced oxygen supply to the brain, causing them to have an episode of syncope. So there are certain laws that you need to be aware of that are quite physicsy, but Brussel's law describes the resistance to flow based on the radius and length of a vessel and the fluid viscosity. And so the equation is there, which is the resistance, which is equal to 8 times the length of the tube or the blood vessel times the viscosity of the fluid, all divided by pi times the radius to the power of 4. Another concept that you need to be aware of is autoregulation. So, as I mentioned earlier, there's pulse pressures between your peak blood pressure and your peak diastolic and systolic blood pressures, whereas tissues need to maintain a steady blood flow despite this change. And this is known as autoregulation. This also can happen is also important for when your blood pressure increases, say in times of fight or flight, as tissues need to ensure that the right amount of blood flow goes to your vessels, because if there's too much, then it can be damaging. And if there's too little in times of low blood pressure, then the tissue can lack oxygen and become necrosed. And so this is why autoregulation is really important. And it happens within a set physiological range, as shown on the diagram to the right there. So there are a few factors affecting local vascular control. One of these is temperature, and this is nicely demonstrated in your skin. where there's vasodilation in response to heat and vasoconstriction in response to cold, which helps your body regulate its temperature. Metabolic factors also impact vascular control. So substances such as adenosine, carbon dioxide, and hydrogen atoms can cause tissues to vasodilate, as it shows that there's an increased oxygen or nutrient demand. The vessels themselves also have a myogenic property, which means that they can contract in response to pressure, helping vascular control. You need to be aware of nitrous oxide, which is a potent vasodilator. This is produced in endothelial cells by the enzyme nitrous oxide synthase. This then travels to the smooth muscle cells underneath the endothelial cells of the vessels and activates the GMP pathway, which activates PKG and causes smooth muscle relaxation and thus vasodilation. The sympathetic system also impacts vascular control, and adrenaline acts on both beta-2 adrenergic receptors, which cause vasodilation, and alpha adrenergic receptors, which cause vasoconstriction. It's important that there are these two separate responses so that in fight or flight situations, blood is directed where it needs to go and away from where it's not needed. For example, your muscles, allowing you to run faster, very much need more oxygen and more blood supply, whereas other processes in the body, such as digestion, are not so urgent at that time, and blood flow will be directed away from these areas to accommodate the increased need elsewhere. Hyperamia means increased blood flow. So this could be active, which is determined by the metabolic activity of the tissue. So decreased oxygen, increased carbon dioxide, and increased potassium will cause vasodilation to increase blood flow. And if there's increased oxygen and decreased CO2, this will conversely cause vasoconstriction. Conversely, reactive hyperemia is similar. However, the change in oxygen and carbon dioxide is caused by temporarily interrupted blood flow, such as something limiting the blood flow and then causing the change. Another concept that you need to be aware of are stalling forces. These are the forces that control fluid movement between blood vessels and tissues at the capillaries. So it describes that near the arterial end of the capillary, fluid is squeezed out of the capillary by the blood pressure, which is the hydrostatic forces, which are large at that end, as they're near the high blood pressure arterial side of the circulation. And then closer to the venual end of the capillary, this hydrostatic pressure and force will be much lower, and so fluid will be pulled back into the capillary by the osmotic pressure, which is caused by the proteins in the blood. This osmotic pressure actually stays the same throughout the capillary, but it's that the hydrostatic forces change from larger at the arterial end to much smaller at the venual end, causing the difference in the net change of fluid, driving fluid to leave the capillary and then to enter it at the venual end, which allows the transfer of oxygen and blood to come back. And this slide just explains that again. So now we'll move on to talk about sensory receptors and reflexes in cardiac physiology, which is under your syllabus at 8.6.6. So you need to be aware of arterial baroreceptors. There you have two groups of them. There's a group in the aortic arch, which are innervated by your vagus nerve, and a group in the carotid sinus, innervated by the glossopharyngeal nerve. These are both cranial nerves and are also denoted by Roman numerals. So the vagus nerve is the 10th cranial nerve, the glossopharyngeal nerve is the 9th. These then, so when these sense low blood pressure, the signal will be sent up these nerves to the NTS, which will then transfer the information to the medulla, which can then trigger responses to cause, say, sympathetic response to then increase blood pressure. And this means that your blood pressure will never drop too much and can maintain, so you can maintain a good blood flow to the organs that need it, say like your brain, which is really important for consciousness. Yeah. You also have low cardiopulmonary receptors, and these are found in the heart, the lungs, and the pulmonary vasculature. These sense decreases in arterial pressure as decreased stretch. And similarly, these are processed by the medullary cardiovascular control pathways, and can cause an increased sympathetic activity and then decrease your parasympathetic activity to increase arterial blood pressure. So I have a few multiple choice questions. If everyone could join the Mentimeter there, and if anyone could let me know if that's working as well. Great. Okay, so I'll just give it a few more minutes if anyone else needs to join, and then we'll start going through the questions. Can everyone see that on the screen as well now?
We can't see anything at the moment. It's just a dark screen.
Okay, sorry, thank you.
Might help if you could stop sharing your screen just momentarily and then see if it works then. Because if everybody's already logged into Mentimeter, it should be okay. They should be able to read it on their phone.
Yeah. Sorry, guys. Let me just try one more time. So can you see my screen now?
We can see that you're sharing the Zoom call. Yeah, we can just see the icons.
Okay, one moment. Otherwise, I might just talk through it if you've all got the questions up on your phone as well. So I think the first question has gone on the Mentimeter, which was what produced the first heart sound. And this, as I said earlier in the presentation, was the closure of the mitral and the tricuspid valves. So this is as heart flows in to the ventricles then contract, and this causes those valves to close while the aortic and the pulmonary valves open as the heart is pumped out. And the heart sounds are made by the blood pumping, hitting the valves as they close. Does anyone have any questions about that? Okay, so I move on to the next question now, which is, should be hopefully up on your Mentimeters. Okay, nice. Looks like you've all got that right, and yes, it is the pacemaker, it is the SA node, which is where those electrical signals start due to the funny current of the heart. So this goes between 60 and 100 beats per minute as your sort of normal values. It's worth noting that if the SA node fails, there are secondary pacemakers of the heart, so the AV node can then take over and spontaneously depolarize and cause the ventricles to contract. This doesn't normally take over in healthy hearts as it depolarizes at a slower rate, so this goes at between 40 to 60 beats per minute compared to the 60 to 100 of the SA node, which is really important because it means that the AV node in a healthy heart won't spontaneously cause the heart to contract out of rhythm with the atria and the SA node. Great. So we'll move on to the next question now, which is, what type of drug is a warbane? Great, so mostly right, and to be honest, it can be used as an antidysphotic as well, so whoever put that as their answer is correct in a sorts too. So it's primarily a cardiac glycoside. And as I said earlier, this acts on the sodium and potassium pump on cardiac myocytes. So we're moving on to the next question now. So this was, what were the adrenergic receptors on the heart? And most of you have correctly put that they are the beta-1 receptors. Beta-2 is found in the vessels, as is alpha-1 and alpha-2. And I'm glad that no one put the muscarinic receptor, M1, which, as the name suggests, is a muscarinic receptor. So moving on to the next question. Okay. So this question caught a few of you out. It was which of these was an adrenergic agonist? It's important to know that propranolol is an adrenergic antagonist, so it works sort of the opposite way to an agonist does. Drugs are kind of commonly come up as multiple choice questions in your exam, so definitely worth, it's just a fact, and if you don't know it, is obviously it's okay if you don't get it right straight away, but they're kind of easy ones to learn and hopefully shouldn't be too complicated. So the other drugs on the list, so propranolol, as I said, is an adrenergic antagonist, a beta blocker. Atropine is a muscarinic antagonist. Dobutamine is an adrenergic agonist. Awalbane, as we just covered, was the cardiac glycoside. And verapamil is a calcium channel blocker, which is one of those antidysrhythmics that I mentioned earlier. So we'll move on to the final question now. Okay, so this question was, what is the afferent pathway of the aortic arch baroreceptors? And the majority of you put either cranial nerve X or vagus nerve, which I hope you kind of noticed the same thing. So the cranial nerve 9 and the glossopharyngeal arch are to do with the carotid baroreceptors. And again, that's just kind of one of those facts that's worth learning because it does come up in exams. And then sympathetic and parasympathetic nerves are the efferent pathways of the baroresponse, which then I sort of remember it as efferent gives the effect. So what you want to actually change to bring the system back to homeostasis. So that's sort of the end of my quiz now, and sort of the end of my content. Sorry, I realised we've whizzed through it very quickly. Does anyone have any questions about any of the content or any other slides that they'd just like me to go over again because you didn't quite catch what I said? Feel free to put anything in the chat as well.
If not, Romilly, do you mind putting the QR code up on for everybody to scan so that they get the slides and the questions, please?
Yeah. Is that up there?
Yeah, perfect. Thank you so much. So if nobody has any questions, if everybody just scans the QR code, I'll send everything through and I'll leave it on there for a couple of minutes. So thank you to Romilly for today's session. And if anyone has any questions in the meantime, they can email either myself or Romilly. Thank you.